Good morning, everyone. Thank you for the opportunity to present this morning. As Philip just mentioned, we've had the opportunity to take part in 3 independent evaluations of VASM since it was first formed, and the most recent of those was last year. So the first 2 evaluations that had occurred were largely quite technical evaluations. They were looking at what VASM was funded to achieve, to become established and get surgeons on board, look at the level of reporting, look at the nature of the outcomes from the audit. And that was the first 2. The second one then focused on what are the indicators that VASM should look at moving forward as a sort of sign that it was being successful. This most recent evaluation, though, it coincides with a contract renewal. So VASM, as is all of the state and territory audits of surgical mortality, are funded by their respective state or territory governments. So the money basically comes from the government through the college to VASM separately, and then those results get aggregated up into ANZASM. And a lot has changed on the government front in Victoria, particularly over the last 5 or 6 years. So I wanted to start today there we go. I want to start today by actually talking about some selected trends in the Victorian context in relation to quality and safety and where VASM sits. This is selected, there'll be other things, but for those people that are unaware, there's actually been quite a long history of quality and safety, and it does set the context for what this evaluation is, and as Philip's presentation said, where VASM needs to go into the 2020s. So pre-existing, there will still be a few people around that were operating back in the day, or at least familiar with back in the day, when most of the adverse outcomes from surgery were reviewed in local M&M processes or coronial investigations. There was monitoring of particular adverse outcomes, but it was selective, ad hoc and dependent upon each clinical unit and each health service. Now, in 1962, in Victoria, the first systematic data collection relating to quality and safety of outcomes was implemented, and that was COPM, the Consultative Council on Paediatric and Maternal Morbidity and Mortality. The date doesn't say in COPM's history, but the date is kind of significant because, in fact, in 1961, there was a fairly significant medication that was taken off the list in Australia, and COPM started the year after that. It was subsequently enhanced, but has represented a systematic data collection of all births that are occurring in Victoria. It's peer-reviewed and there's feedback provided. That existed for a while, and then about 15 years later, VCAM came on board. The other historical influence then started in the 90s, and that was with the introduction of what we refer to as case mix funding. Now, some people in this room may understand case mix funding in a lot of detail, some may not. But the essential essence of it is hospitals, instead of being given a block of money to say, there you go, they looked at the profile of the types of patients that were seen and how complicated those patients were. So that's how the funding was determined, but coincidentally, it meant that the state government started keeping a record and collection of the state. The Surgical Consultative Council then came in around 2000, and VASM then comes in around 2007. Now, by the time VASM is coming in, we have also got trends at a statewide level, largely, not totally attributed, but largely influenced by what was then called the Victorian Quality Council, which was very much around trying to establish quality systems, governance frameworks for quality. Most people, if you want to see some enduring work from the clinical quality, the Victorian Quality Council, you just have to walk into a hospital and look at a hand sanitising machine. That whole hand hygiene project was first established by the Quality Council and is one of many examples of projects that have continued. But the audit came in there where there was a focus on not just peer review, but self-reflection, and that's actually one of the absolute critical contributions that audits of surgical mortality make. It's not just peer review, it is having an opportunity for surgeons to go away, reflect on a case and think, okay, in hindsight, how would I weigh this up? It is not information that you would see in a medical record, so it's not obtainable in any other way. And, you know, as people will know, medical records aren't self-reflective documents. They're documents of accounts of what's happened. So that came in, was seen, is quite consistent with this idea of getting clinician-led identification of issues, clinician-led initiatives, and was further sort of strengthened, if you like, with the introduction of the Victorian Clinical Networks program. Again, you have networks of clinical experts that are there to identify problems, bring problems to the table, or look at problems that have been brought to the table and identify practical, real-world solutions for clinicians that can be implemented at the coalface. So, that all ticked along until there was the discovery of a cluster of deaths occurring at a particular outer metropolitan hospital, which caused great concern to members of the public in Victoria and to the government of Victoria, as well as a number of other people in Victoria. But as a result of that, there was a massive review undertaken of the Department of Health here in the state, triggered by that, but it was asking bigger questions to say, how could something like that have been going on when, for example, we had systematic collection of data going on back in 1962, or it happened a little further after that, but the data's been collected, we've got better clinician engagement, so how does this slip through the system? Now, that was called the Targeting Zero report, and there are a number of, it's a very comprehensive report, there are a number of conclusions, but in essence what that report said was that the department needed to refocus on taking a system stewardship or oversighting role of health services. Prior to that, there had been a bit of a push for health services to be self-responsible. They're their own independent governing authorities, but that doesn't negate the role of the health department. And in response to those recommendations saying there should be greater oversight, there should be greater use of data that's already collected, there should be better integration of data that is collected from different sources, and there should be greater transparency, involvement of consumers and clinicians. Safer Care Victoria was formed. So it was a specific recommendation of that review that Safer Care Victoria be established and charged with those functions. And then the Victorian Agency for Health Information is a parallel structure within the department responsible for analysis, collection and analysis of data that aims towards system improvement and sharing of information. So that's where we've come. VASM sits in the middle of this timeline, and we're now into this situation of data sharing, data integration and use of it to improve systems. Where is it likely to go? Current trends would give us some indication that certainly within the next 10 years, we will see greater pressure on more urgent detection and response to incidents. Obviously and fundamentally to improve the quality of care for consumers, but not incidentally, the fact that it actually also, we know that it results in longer lengths of stay and costs more to the purse. Prevention is the important thing here. Multidisciplinary review. We know surgeons, doctors, people don't operate in isolation in a public health service. We work in teams, and there is more than enough evidence now to show that different team members capture different things. And we need the perspective of more than just one person in understanding local systems and what goes wrong. There will be a greater focus on care pathways, not just within a hospital, so from a surgical perspective, from the initial admit, be it an emergency or planned admission, through the pre-op workup, through the operative process, through the post-operative care, but into the community, and in addition, from the community in for a pre-op workup. So service integration will be seriously a serious area of focus. We also know that there are emerging trends right now on actually starting to shift the way hospitals and health services are funded to incorporate far more patient-reported outcomes. So it's not just the satisfaction with the service of patients, but it's in fact patients demonstrating change in their level of functional ability, their reduction in pain, improvements in their physical function, their psychological health and so forth. And there will be a continuing pressure to promote the output of information that helps inform consumer choice. That's where we're going. That sets the context for what the current evaluation was about. And so essentially there were three components of it. The first was to look at what we call the authorising environment. So the authorising environment is the environment that pays the money, has the strategic objectives that they are happy to fund the college and then the audit to perform and to contribute to. That, as Philip's already said, is obviously ANZASM, the college, but importantly it's the Victorian Department of Health, whose objectives, as we've seen on the previous slide, have now refocused and shifted. We also wanted to know the value of the audit to a range of stakeholders in terms of what it's doing. Is it perceived credible, trustworthy? Is it giving information that people think is useful? If so, how are they using it? And then what are the implications of all of those things moving forward into the next contract period and aligning with future directions in terms of quality and safety? Very briefly, we looked at a summary of performance in this case, and a lot of the activity of this evaluation was gathering verbal feedback from people. We did it either via survey and through targeted interviews of a range of people that use the information that VASM produces. Very top-line findings, and Philip basically was talking to this in his presentation, so I won't go into a huge amount of detail, but the big question, the starting question is, well, what's the capture rate of VASM? What's the VASM's enumerator in terms of the number of surgical deaths reported? What's the denominator? And we see that VASM's coverage of surgical or procedural related mortality is actually very, very high. In fact, it's considered to be far higher than this represents. As Philip said, this data, the denominator includes things like cardiac catheterisation, the radiology type of procedures, scopes and the like. So as this data gets cleaner over the next few years, we would expect that coverage to be tucking up right near 100%, if not on 100%. You've seen this slide. At the same time, since the audit has become mandatory in terms of participation through continuing professional development, we can see a trend. It's not significant, but it is an upward-looking trend in relation to the rate of the crude rate of procedural mortality in Victoria. Most importantly, I did a quick snap check of that rate yesterday in terms of currently published international literature, and 3.1% came up in the first article I looked at, which was a summary of post-procedural mortality in the United States. So it's within range. But in the context of that, it is encouraging to note that there's been a decline in the rate of potentially preventable events associated with surgical intervention. You could argue that's one of the most fundamental things VASM's actually aiming to reduce. You can't get rid of all mortality, but you can identify if it's potentially preventable and reduce that. That is a significant reduction if you compare 2013-14 with 16-17. It needs continuing monitoring. That 2016-17 just in fact could be a blip if I'm applying my cynic's hat to it. We need to look to see if that's at least maintained or continues to decrease. That's encouraging, but following up questions that were actually asked this morning, brilliant questions, the sort of question is, well, how? How is VASM actually doing anything or influencing that outcome? The answer to that is mixed. Glass half full or glass half empty? We'll take the glass half empty approach first. This is feedback from a range of surgeons who we surveyed as part of the evaluation. What we did was we said, has your clinical practice, or which elements more specifically of your clinical practice, have been influenced in any way by the activities of VASM? Now, if we looked at the way they document information in the medical record, case evaluation within units, case discussion with peers, decisions to operate at all, the type of post-operative monitoring, pre-operative care, and choices about the type of surgical approach. Now, in the what looks like brown there, they are the people that said no, it wasn't influenced by VASM at all. We can see that's roughly around 50% for most of those elements of practice, with the exception of the type of surgical approach where more people said that that's really not influenced by anything VASM does. Flipping it to a glass half full, that means around 50% said it was, or it did influence their practice. And so we then asked them, okay, if it influenced your practice, what was it about VASM that influenced that element of your practice? Was it the fact that you had to report? So that's in your head, you know you've got to report it through. Was it the feedback you got as an individual surgeon? Or was it the case review booklet? The case review booklet is in the darkest green, and where VASM did have an influence, it was in fact those surgical case studies that had the most influence. So, VASM is having an impact, but the conclusion from this sort of information, from surgeons directly, but also from the range of other stakeholders, is that we need to understand more about how VASM is actually influencing change. We all know, if you've been involved in quality and safety initiatives, you can't attribute an improvement to quality and safety to one initiative. There's so much going on. It's a very, very complicated space. But we also know that most of the improvements in quality and safety, whilst they may be sponsored at a state level, at a government level, indeed at an association level, at a craft group level, they're implemented at the health service level. And it's health services that are fundamentally responsible for the outcome of the patients that they treat. So what we see is there is room to improve and room to make better use of the information collected by VASM, particularly for improving local systems of care. So more can be done. The feedback we got was very clear on this point. The question that was asked just before about health services, we need more information if we're going to make improvement. Very strong messages coming through. The government saying, we want to integrate information to develop a picture of whether or not what we're seeing is consistent or inconsistent. All very, very strong messages. So the question we were then left with is, well, where do we go in order to try and balance the needs of those different people who want to use that information? If we summarise the key areas of the audit, and this is just jumping to the conclusions, and I'll go through some specific recommendations in a moment. What we see is that VASM is really strong at integrated structures, processes, having built the trust, credibility of to surgeons. It's a very successful system for audit, and the levels of ongoing participation are essentially secure, so long as nothing really major changes in terms of to current arrangements, and I'll talk about that in a minute too. The threats, however, are that VASM's original purpose has now, it's stayed its course, but the change, there's been a divergence in emphasis by the government, so the alignment to the Victorian health system's objectives has now just come out a little bit. And similarly, the reporting of outcomes is not considered to be helpful or utilised as much as we might want it to be from a VASM perspective. Therefore, the main area of weakness is currently, and it's a relative area of weakness, is using those findings to actually improve outcome. Current methods are a little bit hope and pray, as what people will tell us. You know, it's hoping that the feedback leads to an improvement, but that in itself is not sufficient to place all of that onus on a surgeon. It is the local system. So that generates some ongoing areas for improvement, which I'm about to whiz through now as the main recommendations of the most recent audit. And let's see if the IT system, there we go. Strategically, everybody's focused on the same aim, which is to maximise the outcomes for patients. But in order to then align the good stuff VASM's doing now with the directions of the government, who are the ones that are likely to be providing ongoing funding, there are 4 areas that we can organise our recommendations around. First of those is to be clear and recognise the partnerships and contribution of surgeons to the process and the audit, where in terms of another piece of the puzzle that sits in there for quality and safety improvement. The next is to maximise earlier detection and review of issues, particularly significant cases or cases that might be signalling an underlying issue. Improve the focus on systems. Again, I'm going back to an earlier question which was asking where in the hospital does it occur. There's some more work that VASM's already been doing, but it can be strengthened in that area, and then to get better use of that information. So just going through those briefly. First recommendation is the thorny issue of confidentiality, and the recommendation is to maintain that, but the review recognised that there is a tension between the sharing of information and the confidentiality of that information. I will talk briefly in a minute about ways to overcome that, but one of the things that needs to be the thorny issues that Philip was referring to is that there needs to be a bit of a rethink about where the state legislation sits versus where the Commonwealth qualified privilege legislation sits. Think back to that first slide. COPM, VCAM and the VSCC, as councils, have specific bits of legislation that they sit under that actually ensure confidentiality. VASM did not, and therefore it needed to seek a common ground for all the other audits, and it went for the Commonwealth approach. So there's some resolution that needs to happen there to enable better exchange of information whilst protecting the actual confidentiality of surgeons. We've recommended an expansion of the audit objectives. We're not chucking anything out, but in order to kind of reinforce the confidentiality, we have suggested, recommended that the audit actually make clear that it's about a no-blame focus, because that will actually move together with the confidentiality, but also that it's about it's another method of case detection. It's not just as a cynical view, a number of them had said to us, just a closed surgeons club. It's in fact a method of case detection that benefits from the experts' review, reflection and peer review of their own work. And also that it's actually about improving systems of care, not just individual patients. Next recommendation is more timely case preparation. This is a procedural recommendation. In Victoria, unlike the other states and territories in Australia, there's reduction of potentially confidential information from hospitals. It's recommended that that be removed. It does not exist in the other states or territories audits. We have recommended that an attempt be made to try and find a system of identifying, triaging, if you like, significant cases that are reported in to VASM. Not just significant cases, but very importantly, case clusters. Cluster level investigation has occurred, but it hasn't been a specific focus of the audits. And again, as many of you are most likely know, cluster investigation is problematic because you can get sub-threshold cases moving through the system, and it's only when you actually start to look at common underlying patterns does a cluster seem to emerge. It's a tricky area. It's an area, though, that we have recommended that VASM further consider. The next is that where there are significantly sort of triaged or priority cases, there's a process of expedition of those cases, expediting them for a second line assessment straight away so that the full medical record information be utilised at the first port of call. The next of these recommendations is that the care pathways are analysed. Now, VASM's doing this now, and they have been doing it for some time. We recommend it move into the formal reporting. So at the moment, you can read a VASM report and it will talk about medical diagnosis, preoperative, operative, post-operative. Underneath that, there are steps that are coded in the VASM data about the pathways in each of those sections. And what we are suggesting is that the reporting get improved so that it actually focuses on where exactly in the care pathway. It's consistent with local systems of care, and it provides information for not just the surgeon to go back into their local unit and say, look, it looks like we've got issues at this point along the process, but it can then, that information can be aggregated, not identified for surgeons, but it can be aggregated and provided in summary form to health services to help them understand whereabouts in their systems of care issues are occurring. And again, for those that are reporting, you'll know this. For those that don't report into VASM, there are 4 levels. There's actually, you can divide them into a number, but VASM, the reviewers will look at areas of consideration, they'll look at areas for concern, they'll look at potential adverse events, and then of those adverse events, they will look at those that probably just really weren't potentially preventable, and then at the tippy top, if you like, of that inverted pyramid or inverted triangle are the potentially preventable ones that they really want to get to. They can all be aggregated, because if there are systems or processes of care issues, you don't just have to report the tip. You can actually go back and have a look at any issues along the care pathway, and that is one of the things we've recommended. The other very basic thing is to actually ask surgeons on future forms, what do you know has changed as a result of any review, either VASM or other reviews in the hospital that have occurred in response to this case? We need some better linkage, cause-effect linkage, to try and understand what's VASM influencing or what's VASM triggering, or is there a co-trigger occurring within a particular health service once there's a death of a patient? We need to unpack that a little bit more, and that's how we're recommending that occur. For the tip of the triangle, the potentially preventable adverse events that influence or look to possibly influence the outcome of the case, we're suggesting a multidisciplinary review. Now, David's going to talk about that process in a couple of presentations' time, but we think that's really important, again, to get the broader perspective. How that is done needs negotiation with the department as they work out what they're doing with the surgical council, with any perioperative process, review process, but we're suggesting a linkage occur there. We are asking that reports be, again, enhanced. A lot of work has gone into VASM reports over the last number of years to just continually improve them, to target messaging, and to really try and tailor them for specific audiences. We're just asking for another little one, which gets back to that systems of care, process of care, summarising of information. Hospital rates, Philip put these up on the last graph. We think that's important, so long as they are annual rates and they're not amalgamated rates, so that hospital 172 doesn't stand out unfairly. Now, to be fair to VASM, that graph that Philip first put up was actually done in response to a specific request to see what that would look like from the department, actually. The second graph you put up looks like the one we did, which was one of those ones that took that information and said, okay, let's try that, but now let's just compare it to Victoria instead of the annual audit, and now let's look at it year by year, because we want to see the shift. It's actually the shift in hospital that's important. Yes, that some hospitals are in the outlying margins or indeed are outliers we want to know about, but we want to see progress, shift, change. If they're heading on the outer, that's really important. If they're heading on the inner, that's really important too, because we want to know what they're doing, because there's some practice lessons there that can be learned. The loop needs to be closed further. So by reporting at a systems-based level, aggregating that information up, back to surgeons, to specialty areas, to craft groups, to health services, there's also a realistic public requirement to show that the department, with or without VASM, are closing the loop on this. So the annual reporting we're recommending actually start including some case studies about things that were identified through the VASM process and have been subsequently addressed, and what does that mean for patient safety. That's important from a consumer point of view. Otherwise, all you're doing is looking at problems and you're not actually sharing all the active ongoing work the health services are actually doing to improve the quality of the care that they deliver. Finally, that the annual reports are actually done in partnership with Safer Care Victoria. Safer Care Victoria will be responsible for governing the contract to VASM, and that relationship has become more important to make sure that the objectives of both bodies are being intertwined, if you like, and are meeting together. So we're recommending, particularly on the case study side of things, there's a role for Safer Care Victoria there. That will need to be worked out. And Nathan, who's doing the next presentation, actually will be able to talk a little bit more about the role of Safer Care Victoria and that systems focus. That's the summary, where we've come from. The fact that VASM has done very well, but there needs to be a strategic repositioning and a re-emphasis moving into 2020. And on that note, I can take a few questions.